morning, everyone. It is a total honor to be here with you today. I do have a dad joke, actually. I sometimes joke that I have a PhD in stigma, which I do not, because they do not give PhDs in stigma. But it certainly does not take a PhD in stigma or really anything else to know what stigma looks like. So we can see it in how people change, how they interact with people in recovery, how they sort of distance themselves and not in a COVID, social distancing sort of way. We are all experts in stigma here. Some of us have experienced it ourselves in relation to our own recovery. Some of us see it every day at work. And some of us have experienced it by watching family members struggling with addiction. So this is how I became an expert in stigma even before I started my PhD program. Oops. I'll get the hang of it. So we've also all heard the stories. These quotes are from our research with people in recovery. We've heard the stories of fathers making their sons feel like scum for their substance use disorders, stories of coworkers treating people in recovery as less than in the workplace, and stories of healthcare workers treating patients in recovery completely differently as soon as they learn that they're in treatment for a substance use disorder, of changing their attitude and of brushing off patients. So I'm guessing that you've all heard these stories before, or maybe you've lived these yourself. So these stories aren't really new to any of us. What is new and what is exciting is change that's happening in North Dakota among your community members. So your friends and family, your coworkers and neighbors, the folks that you pass on the street. In 2018, North Dakotans were asked, when it comes to addiction and recovery, what comes closest to your opinion? And at the time, 63% said that addiction is a disease and should be treated like an illness, and 28% said addiction is a choice. So we asked North Dakotans this question this summer, so just 2 months ago in August, and things are changing. So this time, 74% said addiction is a disease, and only 19% said addiction is a choice. Now, I have studied stigma that is slow changing, sexism, racism. So for me, this is actually a good amount of change in 3 years. So congratulations, because this change is partly because of the people in this room, and thanks to those who are joining us online. This understanding that addiction is a disease and not a choice also came through in respondents' support for public policies this summer. So North Dakotans clearly want public health-oriented policies. 74% support making naloxone available. Naloxone is a medication that reverses opioid overdoses and saves people's lives. 69% support increasing government spending on addiction treatment, and 46% support laws that protect people from criminal charges if they seek medical help for their addiction. In contrast, only 22% of respondents think that the solution to substance use disorders is arresting and prosecuting people. Few people, only 13% and 8%, think that employers and housing agencies should have the right to fire or not provide services to people who are in recovery. So overall, this is pretty good news. But I also know that you, like me, are eyeing up that 26% of people who don't support making naloxone available, the 31% who don't support increasing government spending on addiction. And some of you are even eyeing up that 13% who think that employers should be able to fire or not hire people in recovery. The folks who are eyeing up that 13 and 8% are my favorites. You, like me, might be wondering how we can push this dial even further, how we can change the rest of these hearts and minds so that North Dakotans in recovery don't run into people who don't think that naloxone should be made available, that addiction is a choice, and who want to see them arrested and not hired. Now, this is where it might be helpful to pull in some insights from those folks with PhDs. So let's see what the scientists have to say about what stigma is and how to change it, and let's hope that there's something in there that can help us dial down the stigma even further. So our definition of stigma has evolved quite a bit from when a sociologist named Goffman first introduced it in the 1960s. Today, theorists describe stigma as a broad social process that emerges at the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination, and it's all happening in a power context. So it's this social process that results in some marks, characteristics, or identities, like substance use disorders, like recovery, being constructed as indicators of a tarnished character, or of certain people in society being seen and treated as less than others. So when I'm using the word stigma today, I'm really referring to this sort of broad social process. Now this is all great and interesting, at least it is to me, but it all starts to feel a little bit fuzzy when we try to think about how does a broad social process, this sort of abstract thing, actually get under the skin and harm people's recovery. Well, this broad social process of stigma is manifested, or it's really expressed and it's experienced within our structures and among individual people as what we call stigma manifestations. And these stigma manifestations are a really good place for us in this room to focus our attention because they are measurable and they are changeable. Broad social processes are difficult to quantify, but we can absolutely quantify stigma that's manifested within our structures and within people or individuals. We can use our scales and surveys to do that. And then stigma manifestations are also changeable. We have evidence-based intervention tools that we know can either reduce these or protect people from them as we're working to change them. We have tools to measure stigma and interventions to change stigma for stigma manifestations at several levels of society. So as I opened today, I focused on stigma experienced by people in recovery themselves, but it's important to note that these folks are surrounded by people in their communities, their family, their neighbors, their coworkers, and healthcare providers who interact with folks in recovery and may be directing stigma towards them. And then we have stigma at the structural level. Structural stigma spans societal level conditions, cultural norms, and institutional policies. And thanks to our society's historical approach to addressing substance use disorders, which has been through punitive policies such as the war on drugs, we have just inherited lots of stigma within our structures. We have many barriers to people being able to access evidence-based medications and treatments, such as those that can be used to treat opioid use disorders, which were highlighted earlier today. As was already mentioned, these medications for opioid use disorder are the gold standard for treatment, and they can really reduce risk of overdose. And yet, I was told about a young man in North Dakota who was kicked out of a recovery house at 10:42 p.m. at night because he tested positive for one of these medications. This young man was at the recovery house because he was trying to get treatment for his addiction. Later that week, he ended up spending 3 days on a ventilator in an emergency room from alcohol poisoning. In employment settings, we have more examples. We often lack policies that can best support people in recovery. Someone with a limited number of sick days may not have enough time to take off for treatment. They may have to face tough choices between their recovery and supporting their family. And then in the child welfare system, we still have a lot of punitive policies designed to separate parents from their children. Turning to how stigma is manifested among our community members, our family, neighbors, coworkers, and healthcare providers, I'm going to focus here on people who haven't necessarily experienced a substance use disorder themselves, or they're not necessarily in recovery. And I want to focus just a moment on how do these people perpetuate or enact stigma towards the folks who are in recovery. So first, community members may endorse stereotypes, which reflect people's thoughts, their beliefs. I sort of like to say that stereotypes live in the mind. Stereotypes are group-based beliefs that are often applied to individuals. People with substance use disorders are perceived as dangerous, unpredictable, responsible for their condition, and not capable of decision-making. These community members may also endorse prejudice, which reflects people's feelings. Sometimes I like to say prejudice is what lives in the heart. Prejudice involves negative emotions and attitudes like disgust and pity. And research suggests that prejudice towards people with substance use disorders is characterized by contempt, and it's experienced as feelings that express moral outrage, like anger, disgust, hate, and blame. And then people may also endorse discrimination, which involves behaviors. So this is what people do. Sometimes I say this lives in the hands. Discrimination involves poor, unfair, or unjust treatment of individuals. This spans rejecting people with substance use disorders socially, firing or not hiring them, or giving them poor medical care. All sorts of behaviors. So the literature also suggests that stigma from a wide range of community members blocks people's recovery. So people with substance use disorders who anticipate or expect to experience stigma from others in the future are less likely to start treatment. Research also suggests that stigma from friends and families leads to worse mental health and continued substance use, because people have learned to cope with poor treatment from others through substance use, and it also leads to less treatment engagement. Stigma from employers can lead people to be fired or not hired in the workplace, which blocks access to a really critical supports for recovery. And stigma from healthcare providers is associated with receiving poor healthcare in general and poor treatment for addiction specifically. Stigma within recovery communities can also lead to isolation from a really important, really outstanding source of social support. So we do have research suggesting that alcoholics and Narcotics Anonymous are very helpful for recovery of some people. They can really work. But when many of the participants in our studies disclose that they're receiving treatment, specifically medications for opioid use disorders, at these meetings, they're told that they're not really in recovery. These folks stop going, and then they lose access to this really outstanding and fantastic source of support. Okay, so we have a good amount of research on stigma. Now we've been through the basics of stereotypes, prejudice, and discrimination, and we also know that these are bad for people's recovery. So what does this look like in North Dakota? So to find out, we conducted the North Dakota Stigma Survey. We joined forces with First Lady, Catherine Burgum, and the Recovery Reinvented team, and Jessica Halsey at the Addiction Policy Forum team. It is my privilege to share these findings with you today, but I would like to offer a really big thank you to Ginny Sawyer-Morris. And, Ginny Sawyer-Morris, she analyzed the data, and I'd also like to thank Braden Kelly for all of these beautiful graphs that you're about to see. They were over there earlier, but thank you to Ginny and Braden. So who participated? There were 2,336 North Dakotans who participated in this study. I run a lot of surveys, and this is really impressive. So Jenny Olson, Joey Ness, and the Recovery Reinvented team did an outstanding job with recruitment here. So many folks in this sample had personal contact with addiction. Almost half of participants had a friend or family member who had experienced addiction. 12% were in recovery themselves, and 8% worked in the field of addiction. In terms of occupations, the largest groups were from healthcare, education, and professional and scientific and technical services. But we also had representation from criminal justice, finance, public administration, and other occupations. To measure stereotypes, that cognitive or thought component of stigma, participants were asked about their beliefs about people in recovery from addiction. Participants mostly disagreed that people in recovery are dangerous, can't be trusted, and don't make good decisions, so this is good news. There were some more mixed views on whether they're to blame for their own problems and whether they're unpredictable. Turning to discrimination, that behavioral component of stigma, what people are doing, there's some good signals in here. So here you can see that most people, almost 90%, are willing to work with someone in recovery, have someone in recovery as a neighbor, or to introduce someone in recovery to their friends. And most people would recommend someone in recovery for a job. We've got a little bit more ambivalence around having their children marry someone in recovery, renting a room in their home, or having someone in recovery as a caretaker for their children. Now, as we dig into prejudice, that feelings component of stigma, we're seeing just a little bit more ambivalence. So these are all negative emotions, and here we can see that most participants do not feel that they would be disgusted, angry, or even fearful if they were to interact with someone in recovery. But we do see that almost half of our participants would feel some nervousness, some anxiousness interacting with someone in recovery. Prejudice can also look like the lack of positive emotions, so let's take a peek at those positive emotions. And here we're also seeing a bit of good news. So most participants say that they'd feel supportive, compassionate, and empathetic interacting with someone in recovery. But fewer say that they would feel totally comfortable or relaxed. So now we're down to sort of 60 and 50% there. So between these two scales, the negative emotions and the positive emotions, we're seeing a bit of discomfort, some unease in our participants' interactions with people in recovery. Responses were generally similar across occupation types, but there was a little bit of variation for us to think about. So here you can see that healthcare providers and folks working in community services are reporting the lowest levels of prejudice, stereotypes, and discrimination intent. So that's good, right? Because we would hope that folks working in the medical field would be the most likely to see addiction as a disease. Folks working in the criminal justice and finance and insurance are reporting higher levels of stigma. I do want to emphasize here, though, that there was some important and interesting variation in the data. So some of the folks in the criminal justice group did have quite low levels of stigma, just as an example. And we also found that folks who had had personal contact with addiction or recovery as a loved one, through work, or because they themselves were in recovery, had lower levels of stigma than folks who did not have personal contact. Now remember these questions about policy support from the beginning of the presentation. This is a place where we ultimately might want to see some movement, right? We might want to dial up that endorsement of public health responses and dial down endorsement of punitive policies. Well, here we found that people who endorse fewer stereotypes and less discrimination, those cognitive and behavioral components of stigma, have more support for public health policies. We didn't find that prejudice was associated with this support for public health policies. In contrast, people who endorse more prejudice, stereotypes, and discrimination, the feelings, cognitive, and behavioral components of stigma, have more support for these punitive policies. So to me, this suggests that if we want to dial up support for our public health policies, we need to work on people's thoughts, their behaviors. And if we want to dial down support for punitive policies, we need to work on feelings in addition to thoughts and behaviors. So before I close, I want to share one more lesson from these stigma scientists to help us think about what it is that we can do to further change stigma, to further change people's hearts, minds, and behaviors. Now, unfortunately, there is no one silver bullet to stop the stigma of recovery or substance use disorders, just like there's really no one silver bullet to end addiction itself. But we do have many tools in the stigma intervention toolkit. In other words, we have developed a sense of strategies that work to decrease stigma. We have tools to address stigma at the structural level, among our community members, and also among people in recovery. And when we're thinking about people in recovery, we're more so thinking about that internalized stigma, those feelings of shame, and we're also worried about people experiencing stigma from others. We want to figure out how folks can be more resilient to that as we work on getting rid of it. An important tool for reducing stigma in structures is just to aim for policy change, aiming for policy change at the federal, state, local, and institutional levels. So we can aim to repeal stigmatizing policies, and we do have some evidence that health outcomes for stigmatized group members improve after stigmatized policies are removed. We can also aim to enact protective policies, like non-discrimination policies. We know that these are associated with improved well-being, and so enacting them may improve people's chances at recovery. But my personal favorite strategy in this bucket is just to try to constrain the opportunities for discrimination to happen in the first place. So this strategy encourages us to think about where can we create policies that just sort of circumnavigates people's ability to be stigmatizing. The recent North Dakota Recovery Housing Grant is a really excellent example of this. So recovery homes in North Dakota that receive funds from this grant cannot stop their clients from using medications for opioid use disorders. So moving forward, these homes can no longer kick out young men at 10:54 p.m. for taking medications, even if the individuals running those homes stigmatize medications or have misconceptions about them. So to me, this policy within the housing grant is an example of a best practice for addressing stigma within institutions. But one of our most powerful ways to address stigma among community members is through contact. And contact is how sharing personal stories can change stigma. And the field has a lot of research on this. And this strategy appears to be effective at reducing stigma with pretty much everything we try it with. It reduces stigma associated with substance use, recovery, HIV, other things. And we can get a pretty big bang for our buck here because this stigma reduction tool reduces prejudice, stereotypes, and discrimination. So it reduces stigma in people's hearts, minds, and their behaviors. Contact can either happen in person, like when people interact and then talk with each other, or vicariously, such as when people share their stories through events like this, or also, social media, TV, the radio, wherever you want to do it. Research suggests that contact leads to increased empathy and perspective taking with stigmatized individuals in the short term, and it also leads to more knowledge as people learn about the people that they're interacting with or hearing from. This increased knowledge leads people to question the stereotypes that they may be holding. And it leads to reduced anxiety about interacting with stigmatized folks in the future. So really importantly, this intervention tool, contact and storytelling, can help to get rid of these feelings of discomfort, of that anxiety, of that nervousness that we're observing in our survey. And then over the long term, this leads to lower prejudice or improved feelings towards stigmatized individuals. And lower prejudice paired with reduced stereotypes can lower the likelihood of discrimination over the long term. Although sharing our stories is perhaps one of the most important things we can do to change stigma, I do want to emphasize that it's also one of the scariest, least comfortable things that people can do. So these data come from a survey of almost 2,000 people in recovery from substance use disorder. And what you can see here is that people felt pretty comfortable disclosing privately to their friends and families, even a little bit to coworkers. But when we get to more public spaces, to first-time acquaintances, in public settings like this one, and in the media, 40 to 50% of people are not at all comfortable. And it's less than 20% of people in recovery who are comfortable with doing this. And this makes sense, right? I mean, we just spent like 10 minutes looking at data about how nervous people are, interacting with folks in recovery. I'm sharing these data because I think that it could feel easy in the 5th year of this event to take it for granted that people are willing to share their stories with us and that they do it so well, so beautifully. So I just want to reflect on the fact that it takes so much bravery and courage to do this. And I want to offer up thanks to the folks who are making these disclosures today, who are here sharing their stories. Because getting up here and sharing data and talking about the science is like the easy part. The real hard work is in the storytelling. Speaking of the impressive ability of people in recovery to defeat stigma, peer support interventions can help to reduce stigma among folks who are in recovery. Peer support interventions involve people in recovery providing support to each other. And research has shown that peer support enhances empowerment, it improves self-efficacy, and it reduces internalized stigma. Those feelings of shame and feeling less than others due to one's substance use disorder or recovery. I just learned about North Dakota's peer support program. They have trained 600 peer support specialists to provide support focused on advocacy, coaching, and mentoring to people in recovery. And that's incredible to me. It's an army of folks who are here to help reduce one of the very worst aspects of stigma, internalized stigma, and help people be more resilient to their communities when they do run into it. Finally, here's a tool that I hope that all of us can take away from today. So it's a small, mighty-based strategy to address stigma, and it's to change our language. So research shows that language can spread stereotypes. So individuals who are described as substance abusers are seen as deserving of blame and punishment, as unlikely to benefit from treatment. But research also shows that language that is scientifically accurate and person first, like saying a person with a substance use disorder, has been shown to promote perceptions that substance use disorders are chronic, yet treatable health conditions. My favorite fun fact from this visit to North Dakota is that the laws of North Dakota actually referred to habitual drunkards until 2019. So Pam Sagnas and the heroes over at the Behavioral Health Division got this changed, which is fantastic. I can't even imagine, what kind of stereotypes and prejudice the label habitual drunkard brought up until then. So we have many more tools. The trick is to figure out how to use these tools or how to implement them in ways that make them most effective. We have some evidence on how to do this. We know that multi-component interventions that use more than one of our stigma reduction tools at a time are more effective. We know that multi-level interventions that address stigma at the structural level as well as among individuals, both community members and folks in recovery, are more effective. And we also know that longitudinal interventions that use our stigma reduction tools over time are most effective. So on that note, I just do want to congratulate and thank the Recovery Reinvented team for doing this for 5 years, as well as for all of the other components that I hear that they're doing all year round: the education, the advocacy, and the storytelling that they do repeatedly. What would the world look like for people in recovery if we succeeded? So I started off with some sort of sad quotes about people in recovery, about their experiences with stigma. So I'd like to take us out with a happy one from one of the participants in our studies. So this was from a teenage boy with an alcohol use disorder. He came in, he was wearing like this vintage Jurassic Park shirt, so I liked him right off the bat. After he disclosed to his friends, he told us that they completely changed their lifestyles to really benefit me, and we haven't gone to parties this summer. We've been just hanging out at different friends' houses, going on adventures, hiking mountains, doing stuff like that. So here's to working together to finish dialing down the stigma so that every person's recovery story involves just hanging out, going on adventures, and hiking mountains instead of stigma. Thank you so much for your attention. The full report on the North Dakota Stigma Survey is online, so please go to this link to read more about it. Thank you.